And I'm thankful to Dr. Srinivas Kumar and Dr. Sridhar Kasturi. They have put a lot of effort to organizing this meeting. I think this is a great meeting. You'll all enjoy. Our first case with me is Dr. Manoj, Dr. Badri, Dr. Aziz. And for the OCT expert, we have Dr. Akash from Japan. He is the authority on OCT. We have this left main case. I'll ask Dr. Aziz to present the case.
Okay.
Wait for one.
Mike?
I think in the podium in the chair is Dr. Who
Mike.
are in the chair? I couldn't.
Mike.
Dr. Ramesh and
I cannot
Dr.
hear anything.
Yes. Dr. Manoj, I'm Ramesh, Dr. Ajay Kirtane.
Yeah, Dr. Ajay and Ramesh, very good. So this is a very complex case. I think this is, are they showing the life case history? Yeah, this is a 70-year-old man, diabetic, hypertensive. He had a PCI for the RC and LED in 2015. Now for last 1 year, he's having progressive exertional angina. Go ahead. And I'll show LB is ECG is old MI of old antrol MI. Ejection fraction is around 45%. I'll show you the angio. Just show the angio, please. Show the angio. That's the right. He has a stent which is patent but very critical osteal lesion that we'll address later. Can you hear me? Can you? Yeah. So this is a case. 71-year-old man. He had 2 stents earlier in 2015, one in RCA, one in LED. Now that this is the RCA shoot, you can see the stent is patent but critical block in the ostium of the RCA. Go to the left. Can you see the angio film? Okay, that's the left coronary shot. Go ahead. Can you see this left main? There's a left main bifurcation, stenosis at the bifurcation site. Stent in LED is patent, and there's a significant block before the bifurcation. Next. And there is,
I cannot hear anything.
in the LED ostium,
Cannot hear.
there is some block we have to assess with OCT. And the circumflex ostium also looks, there is some block, but we'll do it with the OCT, we'll assess it. Distal circumflex has got a critical block near the OM1, which we have addressed already. I'll show it to you next. So this is the, before we go live, we decided to treat, because of time constraint, we decided to treat the distal circumflex and OM1, and we dilated first the OM1, and then did the stenting OCT of this, which you will be showing. OCT, can you see the OCT?
OCT, CX previous
that's
one.
the OCT we did. This showed very
Initial
block
one.
with 3 millimeter
Second one.
diameter,
First one
and
is,
length was
not
around
so
30,
good, right?
so we took a
Second.
35 into 3 stents, and post OCT, just go ahead. This is the pre OCT picture what you are seeing.
Can I
and,
explain? Can you hear me?
Okay.
Okay.
And,
This is pretty.
This I'll ask Dr. Akasha to give a comment on the OCT picture.
Yeah.
Go ahead, please.
Okay, this is an OCT before stenting. You can identify the very severe stenosis with spotty calcium. By angio, we can see a lot of calcium, but the calcium is only a spotty, so there are no big problem, right? I try to show you the distal landing zone. We decided here to be the best place of the distal landing zone. The diameter is around 2.1, and there are significant stenosis. And here you can identify the OM branch, right here. And there are some stenosis in the OM branch. And then we move to this side, the proximal landing zone. Here is 3.1, nearly 1. So I recommend 2.75. And the length I recommended first is 33, but we use the 35, right? And after putting a stent, I will show you the result.
So one thing to comment on in terms of the OCT-based measurements is, remember the OCT has better resolution for items near the lumen, and so in terms of sizing, it's very important to try to get EEM to EEM type sizing. Additionally, because it's accurate, more accurate in some senses than IVUS, but IVUS will inflate your lumen measurements, and so that was even seen in Illumian 3, where you got smaller sizes relative to OCT sizing versus IVUS sizing. So when you say that the diameter is 3.1, were you measuring across the lumen, or is that media to media?
Are you able to hear?
Yeah, we can hear you.
My mic also is gone, I think, is it?
Can I hear me?
Yeah, we can hear you.
Can you hear me?
Hello?
Hello?
Yep.
Dr. Rath,
Can you
we can
hear
hear you.
Hello?
Looks like they cannot hear, but what Dr. Kirtane is saying is right.
Hello?
You cannot measure from the lumen itself and decide on the stent size
Hello?
compared to IVUS.
Hello?
Then you might actually choose a smaller stent. Is that right, Ajay?
I cannot
Yeah.
hear anything.
Hello?
Hello? Hello?
See, so when interpreting OCT images, this looks, very nicely opposed throughout. There's no mismatch on the flyover. But the question of expansion is one that needs to be resolved either by using the automated measurements or actually measuring in a normal reference segment to determine the size of the vessel. Because I simply can't believe, for instance, that, at the distal vessel, that the vessel is only 2.4 millimeters. That seems, somewhat
You can always
inconceivable.
show instead of just show. No. Yeah.
Dr. Ruth, can you hear us?
Yeah. Okay, fine.
okay, fine,
So
fine.
I think that Akasha is explaining about the result after the stain. Can you show us the result? Can you hear it?
Yes, we can.
Can
So
you see?
what we did, this is a new software of the OCT, metallic stent optimization. You can see the other result very clearly. You can see this. There is absolutely perfect stent opposition, and there is no, in between there was an area where the opposition is not perfect, that we redilated again. You
Okay.
can you go ahead to Akasha, please?
Yeah, this is a distal landing zone. Our position is very good. No incomplete opposition, right? All white. That means well opposed. And this is a proximal landing zone. Also, the opposition is very fine, and you can hear the LED, right? And this is a fly-through image, so you can see.
Can you click on the lumen area measurements, though? On the drop-down menu, there's a way to calculate the areas,
Oh, okay.
so we can see it frame by frame.
Yes. Lumen diameter in the distal is 2.5 and proximal is around 2.88, right? And the MLD is 2.3, so diameter stenosis is only 13%. So
Right, but see, this seems way too small. So is there a way that, can you click in the drop-down on the OCT menu, there's a way of actually showing slice by slice what the area calculation is?
okay. Could you show me that? Not 3D, right? Oh, 3D.
Yep.
Okay. Can you see the cross-sectional area?
Yeah, hit lumen contour.
Yeah, so,
Lumen contour, if you click on that.
okay, right. Here is the distal landing zone, right? Area, the diameter is...
No, but if you click on the box that says lumen contour there, on the top left,
yes,
top left.
Yeah.
Yeah, here is the lumen, yes. No.
Area multiple points, there you go.
No, you
No,
go
see-
to the lumen. It's okay?
You see the box on the top left where it says lumen contour? Click on that box. Yeah, see, so now it shows you what the area measurements actually are as you slide back
Yeah.
and where the dots are. And so the challenge here is that your area that's being derived is based upon the lumen only, and that's why the areas appear small. And if you come back to the area of the MLA, which is only 4 millimeters, that is an undersized stent for that area of the circumflex.
Area is 5.23, right? In the distal edge. Should be okay.
No, that's okay, but if you see where the yellow is, where the MLA,
Yeah, MRA, yes. This portion is a little bit small, I agree. But here is some calcium spot you can identify here. Can you see here?
yeah, I can see it, but my concern is,
very thick, spotty calcium.
Yeah,
If you dilate, aggressively dilate to the normal portion, so it may make some damage in the vessel, so we accept this condition. Only this portion a little bit smaller compared with another portion, but if we think about the vessel damage, it might be acceptable. How do you think?
I don't agree.
No, you don't agree.
I would post-dilate.
We did the
Okay,
post-dilate.
we take your point, we'll do it later, but let's go back to the left main. What do you think about the left main? Can you show the left main OCT? OCT of the left main. OCT of the left main, okay. So the OCT of the left main and ostium of the LAD and circumflex.
Can you see the
This is
OCT
the
image?
OCT of the LAD. You can see the old stent, intimal hyperplasia, which is not very severe. And come back to the left. This is the LAD, isn't it? This is the ostium of the LAD. This is the left main. What is the diameter stenosis? Diameter, can you tell us?
42%.
42% is the stenosis. And what is the minimal
Minimal
area?
diameter is 1.6.
Minimal area is diameter
Minimal
1.6. And what is the minimal
Area is 2.3.
2.3. So minimal area is 2.3. Diameter is 1.62 minimal. And in some views, this is the only view where the left main is significant angiographically. Many views we miss it. So the question is whether to be treated or not.
I mean, that looked more like osteal LAD for me.
Yeah, here is just proximal orifice, LAD, right? And also here is a bifurcation and also some disease in the left main distal, right? And the left main is here, nearly, hello?
This is the significant
No.
left main.
We
And LAD ostium, how much is it?
cannot
LAD
hear
ostium?
anything. Can you hear me?
Yes.
Can you hear me?
Yeah, we
L6
can hear you.
So the L6 ostium also. Hello?
Hello?
We can hear you, Dr. Rath. We can hear
These
both.
fellows are doing.
we agree the left main looks real, and the area measurements, although not prospectively validated for OCT, are concerning enough that given
we'll
the clinical
finish the
scenario,
little-
we would treat.
Yeah, but we missed to the dilate distal portion, right? Yeah, right. So
How about
3
the ostium of the
is too big in the
circumflex?
distal, right? Yeah.
How does the circumflex ostium look as well? Because that,
Hello?
Hello.
This one keeps showing. No, keep running. No. Get and one more view where it is not very clear.
Dr. Rath, we can't see the video.
Hello.
can you show us the video? We just see a freeze of the OCT frame.
So how do you think about the landing portion? You try to put here. This might be the best position, right? Yeah, landing. Yeah. So 2.5, right? Here. Hello.
Hello?
Yeah,
You can see it, you can hear me? Okay, we are just discussing about OCT finding of the left main and ostium of the LAD. And I think left main is significant. This angiographical, in this view only it is significant. Other view doesn't look significant. In fact, you don't find in disease views. And we have also taken the OCT of the ostium of the circumflex. Can you show the ostium of the circumflex?
Yeah, here is the ostium. We already have the OCT from distal CX to the left main. So the ostium of CX should be okay.
Ostium of the circumflex looks okay with the OCT, and you can see it very clearly here. So angiographically there is some haziness, but we are not sure, but it looks on the OCT clear. So the plan is, the disease is from left main to LAD, and we plan to stent left main to LAD and protect the circumflex. That's the plan. And later on we'll do the RCA. So any other comment you want to have?
No, it sounds reasonable. I think in general you would like to get a dedicated pullback from the circumflex back.
Yeah.
But I think you see the ostium's okay, and the one stent strategy is pretty reasonable overall. What's nice about the OCT is you can nail the length perfectly.
Yep.
What size stent are you deciding to choose?
Yeah, there are
The size of the left main is, what is the size?
3.5. 3.5.
No, so that's not true. I'm telling you that's not true. That you're measuring only lumen to lumen, and that left main has got to be at least 4.0.
Okay, so lumen to lumen is 3.5 and 3.87 is the mean diameter.
Mean diameter is,
And that's lumen to lumen, so
Yeah.
that's not the typical way to size stents. You typically want to size media to media,
yeah.
and you're going to get a very accurate measurement by the OCT.
I agree, but there are some discussion how to decide the stent size, media to media and lumen. We always add the quarter size bigger than the lumen area, so it's very similar to the media to media. Right? Still, there are some discussion about the how to decide the stent size.
So what is what should be? Because if you are lumen to lumen is 3.87, media to media will be more. So what is the size you think we should take it? Ajay, what do you think we should take it?
Well, I'm very hesitant to put any stent less than 4.0 inside a left main.
Okay.
And you know that the proximal LAD in a typical male, even irrespective of demographics where they are, is going to be at least 3.5, and so I don't believe that 2.53 measurement in the prox LAD.
So what we do is we take a 3.5 stent and stent it and then dilate with 4 millimeter balloon near the left main. Is it okay? And then do the OCT and check.
I mean, I think I would take a 3.5 and I would probably pot it with a 4.5.
Okay. So we'll take a 3.5 and why do you want 4.5?
Because I'm telling you that this is because the left main, typically, if you have a better view of the proximal left main, EEM to EEM, you're going to see it's an enormous vessel. And
any specific formula, like OCT, if you see 3.87, you have to add something, or just your add 0.5 or something like that.
That's why. You see the measurement?
Yeah.
Now that's not exactly axial. You can go a little bit, more towards 6 o'clock, but that's the difference. And the problem, OCT is a phenomenal tool. The challenge that I often see is that people rely too heavily upon the luminal area measurements, and this is a potential diabetic patient who you're offering PCI as opposed to CABG. Remember, in Excel and Noble, this was done on IVUS in the majority of patients, and so if you're going to try to replicate those outcomes, you have to size it the way you'd size it based upon IVUS. And I'm sorry to keep going over and over again, but I think it's an important teaching point.
We have the IVUS here, but you...
No, don't do IVUS.
No.
You're doing great. You don't have to do IVUS. Just size it appropriately.
Okay, so we go ahead and stent to 3.5 and post-dilate it 4 or 4.5 and then check the OCT.
That sounds very good. And so, Dr. Rath, if you please go ahead and do that, we'll come back to you. We'll switch to the other center.
Yeah, fine, thanks.
Thank you very much. So can we switch to the other center, please?
the proximal part.
Dr. Rath?
Yeah, can you hear me? Hello, can you hear me?
Yeah, Dr. Rath, we are back with you. We have 4 minutes.
Okay, fine. I'll show you. As discussed, we used a 3.518. We have used a biotonic Oslo stent. Peculiarity of the stent is the bioabsorbable polymer and the ultra-thin strut. Now, after this, we used a 4.5 10 balloon to post-dilate the proximal part, and that you can see. And when you do the, you can see in still it is not well expanded. So we dilated aggressively that 4.5 balloon. It was really big. Then we did the OCT. Just show the OCT. So the OCT, you can see in one portion, it is not one point, it is not opposed well. Just show that point. And then circumflex ostium angiographically looked little pinched, but in the OCT it looks okay. So we again dilated with 4.5 with very high pressure, and show the end result. That is the end result. Run. After that. Next. That is the end result. And we did the OCT after that. Can you just show this OCT now? There is, it looks there is little pinching of the circumflex origin, but we have repeatedly done the OCT to look at it. This looks okay. So we didn't recross it. We were thinking initially to recross it, but we left it alone. Now at the end of the left main is around 4.5 to 4.6, and the stent is well opposed, and angiographically the result looks very good. This is angiographically slight pinching of the ostium of the circumflex, but on OCT it's clear. So we didn't want to recross and do anything for the circumflex. So
no, that's great. And I think you can see the red is a strut that's malopposed, but that's because it's right at the bifurcation.
Yeah.
So you don't need to do anything with that. And the nice thing about the flyover view is you can see that you actually had it when you first looked at the origin of the circ looks great based upon the flying OCT view. And the proximal stent is nicely dilated too. What were your MSAs or your minimal lumen areas within the stent in the proximal LAD?
Proximal LAD, how much is the luminal area? It's around LAD. How much? 3.28.
Yeah. What about the areas? If you go a little distal to that point.
Area is...
yeah, 9, that's the distal,
9, yeah.
distal left main.
Yeah,
Just,
that's the left main. Proximal LAD. You want the proximal LAD, is it?
yeah, it looks good though, I have to say.
How much is it, area? That is left main. Ostial LAD. Almost same. Disconnected. Tell them it got disconnected.
So Dr. Rath, can you show us the final angiogram?
Yeah, just show us the angiogram because this is fantastic OCT optimization.
आगे जाओ. 8
Yeah, so these are great. This is great expansion here.
Yeah. Can you see it? It's coming around.
Can you show us the angiogram?
And you can you read the angiogram? That's the angiogram.
Where is the connection? You connected it?
Angiogram, just see the, can you see the angiogram? Can you see the angiogram now?
No, we cannot see the angiogram.
Show the angiogram.
Now we can see it, Dr. Rath.
Yeah. And show the other views. You can see the pinching of the circumflex.
Yep.
And, but if you see the OCT, there is nothing much there to do anything there. It's just probably the LAD when it's expanded, left main, when you expand very much, some visual impact more like, but there is no physiological things. We can always do FFR and all that check, but I don't think with the OCT findings, I don't think there is any need to do anything for the ostium of the left circumflex. What is your opinion?
No, this looks great. I think it's a very good result. You know, it's a tough case. The patient's diabetic. They already have diffuse neointima in the LED stent that was put in just a year and a half ago or 2 years ago. So I think that getting the maximal areas that you can get, which is how you did it, is going to hopefully prevent him from having a restenosis. But this is a great result.
Thank you, Dr. Rath. Excellent demonstration of OCT in this patient. I think we have learned a lot. That number one, I think, is that don't just depend upon OCT lumen to lumen sizing, because you can undersize the vessel stent. So that's very important, as you have shown here. You post-dilated the stents greatly to get a good minimal stent area. Thank you very much. I think, with that, we'll leave Apollo.
Thank you.